I was asked to talk about the management of thyroid nodules in children, and I'll just briefly say that 25 minutes is not a lot of time to cover a very large amount of information. So I'm going to speak somewhat quickly, and I apologize if I gloss over some things, but I'm happy to stay on and discuss afterwards for any who are interested. I have no disclosures relevant to this talk, and I'm going to give a quick overview. This is kind of a few things that I'm going to cover. I'm going to try to focus on the management of nodules, as I think actually Dr. Danya gave a very nice overview of some of the epidemiology and introduced some of the concepts that I'm going to be mentioning. So this is just a clinical case, and I think I'm going to just skip through it. This is a patient that I've seen very recently. He's a 16-year-old boy who had suffered a rib fracture while he was playing ice hockey, and had a CT scan of the chest related to that, and incidentally was noted to have a lesion in his left thyroid, which his physician confirmed on palpation was a palpable nodule in his thyroid. And so I was going to just ask the group just to think what your next step would be if this patient were referred to you for evaluation. A number of options for next evaluation: fine needle aspiration, measurement of various serum tests such as thyroid globulin or TSH. Would you consider referral directly to a surgeon or performing a thyroid ultrasound? And we don't have a polling function, so just sort of think about what you would do as a next step in the evaluation of this palpable thyroid nodule. I will tell you that in my evaluation, the first thing I did was check a TSH for reasons that will become clear, and Dr. Danya mentioned. He had a normal TSH. And then an ultrasound showed these images, which I showed at the beginning, but this well-demarcated lesion in his left thyroid lobe. This is a transverse and a sagittal view measuring about 1.5 centimeters. So we're going to talk about sort of in my view, where the data stand currently for evaluation of these type of lesions. As Dr. Danya mentioned, these thyroid nodules overall are quite rare. There is not a lot of population-based data because we don't go around doing ultrasounds in healthy children. But the best sort of largest data set comes from Fukushima in Japan. This is a study of about 300,000 children done after the Fukushima nuclear accident, and they reported a rate of nodules of what I would consider clinically significant size, over 5 millimeters, in less than 1% of children. The rate goes up after puberty, although it's still fairly rare, and after puberty, more common in girls than in boys, as is true in the adult population. Prepubertal thyroid nodules are quite rare. And then as was also mentioned, the reason we care about these nodules is that the risk of malignancy is significant. So higher in children than in adults. So the adult rate is about 1 in 10, whereas in pediatrics over a range of studies, it was about 1 in 4. And this is one of the early studies that I think was cited from our center directly comparing the rate of malignancy. It was about 50% higher in children than in adults. So the rate of malignancy in a thyroid nodule is higher in children. However, we always stress to parents that still the majority of pediatric nodules are benign. And I think parents are always extremely worried that their child has a lump, and we can reassure them that most of the time it is still benign. However, the risk of cancer is not insignificant, and therefore evaluation is required. And so the whole goal of this evaluation is to determine, is this lump going to be benign or malignant, and how to manage it appropriately. This is, I think, the best resource that currently exists, as was noted earlier. This is the American Thyroid Association guideline on pediatric thyroid nodules in cancer, published in 2015. It was the first version of this, and as such, at the time, there really was very little pediatric specific data. So this is really mostly expert opinion extrapolated from what was known in adults. Since then, quite a bit of pediatric specific data has come out, and these guidelines are currently under revision, and we hope that they will be ready for dissemination hopefully in the next calendar year. So I'm going to try to take a stepwise approach and kind of walk you through the rationale for the evaluation as I see it. Obviously, a careful history and physical exam is important to identify risk factors for malignancy, and I think we've actually covered these in the previous presentation, so I'm not going to dwell on these. But important things such as radiation exposure, any features consistent with one of the genetic syndromes that was mentioned, and I'm happy to expand on those if desired later. Family history of thyroid neoplasia, and in terms of physical exam, in addition to a careful examination of the thyroid, obviously, I always measure head circumference since macrocephaly is a component of 2 of these genetic syndromes. as well as a careful exam of the cervical lymph nodes for any possibility of metastatic disease. So moving sort of quickly through that piece, the next step, as shown in that nice flow diagram from the guideline, a TSH is critical. And the rationale for this is really to weed out those nodules that are autonomous. And Dr. Danya gave us an excellent sort of almost paradigmatic example of one of those in the last case. And the reason for this, as I mentioned, in my opinion, and based on the recent data, these autonomous nodules are very unlikely to be malignant in children, despite what has been sort of promulgated in the guideline based on some older and I would say somewhat biased data. So in this flow diagram, suppressed TSH leads to a scintigraphy to prove the autonomy of the nodule, and the guideline would suggest that any autonomous nodule needs to be resected because of a 1/3 rate of cancer. That is probably not correct. So this is our case series published shortly around the same time as the series from Brown. And if you define these autonomous nodules in a rigorous way, using the following criteria, in our hands, none of these were malignant. So the key criteria are, first, you have to have a suppressed TSH. That is, diagnostic of autonomy. You have to see uptake specifically in that area of the nodule. So the nodule is demonstrating autonomous uptake of TSH, in other words, in the absence of TSH stimulation. And the suppression of uptake in the rest of the thyroid is critical, because if you do not see that, you may be dealing with a patient who has diffuse autonomy, in other words, Graves' disease, and also happens to have a nodule. And that is a very different situation. That's Graves' disease with a nodule, in which the risk of malignancy may be somewhat higher, as opposed to a classical autonomous nodule, in which the risk of malignancy, again, I think is very low, not zero, but low. And so these can be treated with surgery if needed for either size, for symptoms, or for hyperthyroidism. But in my opinion, I think it's reasonable to treat with antithyroid medication and either to observe over time. Iodine ablation can be performed. I'm not going to get into the debate about, is it safe and secondary malignancies in this setting, just because there's so much more to talk about. But it's, even if you did not want to ablate right away, you could certainly temporize with methimazole or carbimazole and plan to ablate at an older age if desired. So I would say these nodules, and again, these nodules, because the risk of malignancy is so low, we do not aspirate these nodules, partly because of the risk of seeing atypical cytology that might lead you to think it is malignant when it is not. So I would put a question mark on this sort of reflexive referral to surgery for autonomous nodules. I do not aspirate these nodules. We treat them as needed for symptoms or hyperthyroidism. If the TSH is not low, then you are not dealing with an autonomous nodule. And I'll just say parenthetically, we see many children who have all kinds of laboratory evaluation for these nodules, which I think don't directly inform the risk of malignancy. So thyroxine levels, although they may help you to learn about thyroid function, are not particularly correlated with malignancy rate if the TSH is normal or high. Thyroid globulin levels do not correlate with malignancy in a preoperative state. And antibodies, although this is an area of much debate, I would say at this point there's no clear evidence that this influences the risk of malignancy in the nodule. So I measure them just to know about future risk for thyroid dysfunction. So these nodules that are not autonomous should undergo ultrasound, and in many cases that's done before, just that's how the nodule is discovered. But the goal of the ultrasound is to identify the suspicious characteristics that were laid out earlier to help you make a decision about whether fine needle aspiration is needed. So this is a stepwise process. TSH, then ultrasound. If ultrasound shows suspicious features, then you would decide to go ahead to an aspiration. These are some of the features that were mentioned. And there's now good evidence, which was not present at the time of the last guideline, to show that these suspicious features that are predictive of malignancy in adults also apply in children. These are 3 studies that collectively comprise about 700 pediatric nodules. So the presence of any of these features would prompt aspiration. And there are different ways of sort of thinking about combining these features. This is a pictorial view from the adult ATA guideline, which has any of these very suspicious features such as calcifications, abnormal borders, abnormal lymph nodes, would be high suspicion. Intermediate would be solid nodules that are hypoechoic, and then these sort of lower suspicion being isoechoic or hyperechoic or having some cystic features or lower suspicion. Another way that's become popular to evaluate these is using these various scoring systems. This is a common one, although there are others, the ACR TI-RADS system. And as you'll see, these are essentially looking at the same risk factors, just assigning numerical point values to them, and then adding those up to get a designation for a level of risk, and then associated with specific thresholds for biopsy based on the risk level. I think that these are quite useful for helping people to categorize or think about levels of risk, but I would caution that these specific cutoffs as recommended in this guideline are not directly applicable to children. And there's been some publications that suggest that they are. This is a publication that we put out a couple of years ago showing that if you apply these TI-RADS recommendations directly to pediatric patients, you will miss about 1 in 5 pediatric thyroid cancers, including 1 in 10 that would have been completely dismissed from any further evaluation using those specific TI-RADS guidelines. So they're useful for thinking about risk, but you can't use those specific size thresholds for determining whether to biopsy or whether to discharge from care. And in general, when in doubt in a child, I would always favor, if you're not going to FNA, it's reasonable to have a follow-up ultrasound evaluation to assess for interval change, rather than just saying, your nodule is a TR1 or a TR2 lesion, you don't need any further follow-up. I would say that probably is not a good idea for a child. I would also just urge everyone, whenever possible, an experienced ultrasonographer can really make a big difference, particularly someone who has expertise in pediatric thyroid ultrasound. Number one, they should always be including an evaluation of cervical lymph nodes if there's a nodule present. We see many patients who are diagnosed with nodules and diagnosed with cancer, undergo thyroidectomy, but no one bothered to look in their lateral neck, which is full of metastatic lymph nodes that should be removed at the time of initial surgery. So a careful ultrasound should always include an evaluation of cervical lymph nodes. But I'm going to show now some examples of why experience is important in ultrasound, because children have some ultrasound features that are different than adults. This is an example of an unusual presentation of thyroid cancer that is seen very infrequently in adults, but actually quite commonly in children. This is the diffuse sclerosing variant of papillary thyroid cancer. And you can see that the gland is not particularly enlarged, and it has these diffuse microcalcifications in it. And this is a cancer. Adult radiologists may or may not recognize this because this is present in less than 1% of adult thyroid cancers, but in children it's actually a fairly common presentation. And this variant is associated with quite aggressive local metastasis and even distant metastasis to the lungs. Nevertheless, if it's identified and treated, they do extremely well, as do most children with thyroid cancer. So it's very important to recognize this and not have it say, well, this is heterogeneous, it's probably just autoimmune thyroiditis. This is thyroid cancer. Autoimmune thyroiditis is its own difficult situation, and I won't belabor this, but certainly autoimmune thyroiditis, if you look carefully, you can say, well, is this a nodular area or not? And this distinction between nodules and what we think of as pseudonodules can be quite difficult, even for experienced radiologists. So that is often a dilemma that we find ourselves in. Sometimes you'll see lymph nodes that will sit right on top of the isthmus of the thyroid that masquerade as nodules, but are actually lymph nodes. So it's another thing to be aware of. And then I'll highlight this because it's become sort of more noted in recent years. So this is a pediatric thyroid nodule that looks fairly concerning. You can see it has a hypoechoic background. It looks like it has lots of echogenic foci in it. This turns out to be a benign variant. This is ectopic thymus. So the thymus can have little ectopic rests that show up in the thyroid that can look quite concerning. This is a sagittal view of the same lesion, and you can see this is the nodule, and this is actually normal thyroid normal thymus in the upper mediastinum in this young patient, and you can see that they look radiographically similar. So this is actually a normal variant that requires no intervention at all. So if you're seeing something like this in a young child, 4, 5, 6, 7, 8, epidemiologically, it's probably much more likely to be ectopic thymus than it is to be thyroid cancer. And so you need to be careful about going ahead and biopsying these. Obviously, if there are other features that are concerning, or if it grows, that's a different story. But this should, like normal thymic tissue, involute over time. So this is an important thing to be aware of. So obviously, sonographic features are going to guide your decision about fine needle aspiration. And I would just highlight here that fine needle aspiration is the intervention of choice, not core biopsy. Core biopsy is more invasive, requires sedation, and is really not necessary for thyroid nodule diagnosis, except in exceptional cases, perhaps. But it does depend somewhat on the expertise available in your center. Obviously, if that's what they have, then that's what should be done. As was noted earlier, Dr. Danya mentioned that the Bethesda system is now, I would say, probably the standard for reporting thyroid cytology. And it was instituted a number of years ago now to try to standardize how we report these and compare them. It has 6 categories of increasing risk, leaving aside the non-diagnostic category, so from benign to malignant. And each of these within the Bethesda system is associated with a specific recommended risk of thyroid cancer associated with that result. And we don't have to get into the 2 different columns, which are probably not as relevant for children. But the point here I would make here is that your cytologist may give you a result of atypia of undetermined significance or follicular neoplasm and so forth. But the rates of malignancy suggested by the Bethesda system were derived and validated in adults. And in my view, based on the data, I don't think that they are directly applicable to children, particularly in these intermediate categories. And I'll show you some data to that effect. So this is the largest single center study that's been done on this topic. So we published this a couple years ago, looking at malignancy rates in different cytological categories evaluated in the same institution between children and adults. So that's very important because there's a lot of variation in how cytology is evaluated among pathologists and centers. So having evaluation of children and adults in the same center is quite important in comparing. And what you see here is the different categories, the malignancy rate on the y-axis, and then children in black and adults in gray. And what you'll see is benign nodules are roughly the same, malignant nodules are the same, even suspicious for malignancy are about the same. But in these intermediate categories, the pediatric rate of malignancy is substantially higher than in adults, even given the same cytologic findings interpreted by the same cytopathologist. And these red boxes are just meant to indicate the Bethesda recommended ranges, just to support that this lab does read adult cytology in accordance with Bethesda. So I think it's just important to remember this, and this has important ramifications for how these nodules may be managed differently in children. In an adult, an atypical nodule might be observed, whereas I think the allowance for that in children is much lower, with at least in our hands, a malignancy rate in the 40% range. These are also center specific, so it's really important to know in your center what is the malignancy rate in each category, because there is quite a bit of variation among centers. So this is just sort of a summary table that I put together based on about 9 or 10 pediatric studies. And it's not important to know the exact numbers, but just to sort of compare, you can see in the lower risk and highest risk categories, the risks are about the same between adults and children. But in these intermediate categories, risks are substantially higher in children. So, I thought I would just sort of outline what we do with specific cytologic results, and I'll try to be somewhat brief about it without getting into too much of the controversy. But once you've established that this TSH is not suppressed, there's a suspicious finding leading to FNA. Obviously, if you get a malignant result, Bethesda 6, that's going to be resected, and we can talk later about how to do that. Inadequate or non-diagnostic results don't really give you much information, so these typically will be repeated, and if it is persistently non-diagnostic, those I would advocate should be resected because the rate of malignancy in pediatric series is around 10% or so. I think lobectomy is probably sufficient for those because the diagnosis of cancer is not certain. Benign nodules are always an area of consternation. People, you do a fine needle aspiration, you get a benign result, and then the question is, what do I do with this? Do I follow it? How often do I follow it? How long should I follow it? And I would just say briefly that there are sparse data on that topic in children. Data in adults are much more robust, but we don't know in children as much. So the current recommendation is to repeat an ultrasound in 6 to 12 months. This is, again, probably I think the largest study that I'm aware of pediatric cytologically benign nodules that we published a number of years ago. And the good news is that benign cytology is quite reassuring, as it is in adults. However, there is a substantial false negative rate for larger nodules, and I recognize there's some debate in the adult literature about whether false negative rate is associated with size. but at least from the data that we have, large nodules seem to have a fairly high false negative rate. So we resect any nodule over 4 centimeters, even with benign cytology. We do the biopsy to make sure that it's not cancer, in which case the procedure is a total thyroidectomy rather than a lobectomy. But if it's over 4 centimeters, it comes out, even if it's benign in our center. In terms of when to follow up, if it's not large and or needs resection, these are data about how likely you are to see growth of a nodule at different intervals of follow-up. So it doesn't really make sense to repeat an ultrasound if you're unlikely to see any change that will affect management. And it turns out that at about 6 months of follow-up, the likelihood of seeing significant growth is around 10% or so. By a year, it goes up to about 25%, and by 2 years, it's about 50%. So in my view, I think repeating an ultrasound earlier than a year is probably not very high yield, unless there are particular features that make you concerned that perhaps that benign result is not accurate. So I think that 6 months is probably too early to repeat. I would suggest 12 months in most cases. And if they do grow on repeat ultrasound, repeat aspiration is indicated as it's associated with an increased risk of a missed malignancy. And as I mentioned, large nodules I think should be resected, and the guideline does say that actually in this footnote number 4. And then finally, there's this issue of what do you do with these indeterminate categories. So first of all, I would say this suspicious for malignancy, or the Bethesda 5 category, probably ought to be separated from these other indeterminate categories. The rate of malignancy in the Bethesda 5 nodules is on the somewhere above 70%, 70, 80, something like that. In some centers as high as 90%. So those are almost certainly cancer, and I think should be resected without question. I think the only debate is lobectomy versus a total thyroidectomy, which we can talk about in a little bit. The indeterminate nodules, the Bethesda 3s and 4s, the atypia and the suspicious for follicular neoplasm, I think there's a little bit more room for discussion, particularly the atypia of undetermined significance, in which the malignancy rate is somewhere in the 30 to 40% range. There's a significant risk of malignancy, but it's not more than half. And so there are a couple of other options. Personally, in our center, we repeat FNA in these atypia lesions because we have data that in about 28% of cases, the repeat FNA is benign, and therefore you avoid surgery altogether. There's quite a bit of interest recently in molecular testing, which, as you may know, has sort of revolutionized nodule care in adults. Data are much more sparse in pediatrics, although they're emerging. I was just going to say a quick word about that, which is that genetic testing works pretty well if you're using a rule-in methodology. That is, if you find an oncogenic driver mutation variant, that is indicative of cancer and perhaps would influence you to do a cancer operation, that is a total thyroidectomy, as opposed to a diagnostic lobectomy. However, many of these platforms that are sort of rule out, that is, if it gives you a benign result from the molecular testing, those are really probably not as reliable in children as they are in adults, because they were designed for adult nodules, which are genetically distinct. And it's important to remember that the negative predictive value of any test depends on the pretest probability of disease. That is, in an adult, this number is actually incorrect. So an AUS nodule in adults now is about 6 to 18% pretest probability of malignancy. So a negative genetic result is actually quite reassuring. It may give you a negative predictive value in the order of 5%. Whereas the same test in a child who has a pretest probability of 30 to 40%, a negative result may only reduce your post-test probability to 10 or 20%, which in my view is not sufficient to obviate the need for resection. So negative results, I think, don't get you out of surgery in a child at this stage. But if a positive result would change your approach, I think it's reasonable to do, although I will say getting insurance coverage for these tests, which are quite expensive in the US, is quite difficult. And so we don't do it very often, but it is an option. And then I'll just sort of conclude by saying a few words about treatment. So I think about treatment for nodules in 2 categories. If you have a preoperative diagnosis of cancer, right, a Bethesda 6 malignant, or probably even maybe a Bethesda 5, then if you have a known cancer, positive lymph nodes, that patient requires a therapeutic surgery, which at this point is total thyroidectomy. Total thyroidectomy is the treatment for pediatric thyroid cancer for now. There's certainly some debate about whether lobectomy is adequate, as it is in adults in many cases. the data are not quite there yet, in my opinion. And so for the moment, total thyroidectomy is recommended. And if you know that preoperatively, the first procedure should be total thyroidectomy. If the operation is being done for a high-ish risk of cancer, atypia of undetermined significance, suspicious for follicular neoplasm, that's a diagnostic procedure, and I would advocate for diagnostic lobectomy rather than total thyroidectomy, for which the risk is much higher. So as I said, malignant cytology or positive lymph nodes, you're going for a therapeutic thyroidectomy, whereas an uncertain diagnosis, such as an AUS, suspicious for follicular neoplasm, or a persistently non-diagnostic, I would opt for a diagnostic lobectomy, with the recognition that you may have to go back for a second surgery, depending on what you find on that initial. And then, as I mentioned, these suspicious ones, the risk of cancer is quite high, and so you could advocate for a total thyroidectomy on that basis. I think that really needs to be a careful discussion with the family, depending a little bit on the expertise and preference of the surgeon, and to some extent other features. If you have a cytology like this, but very clear ultrasonographic findings, such as irregular margins or calcifications that make you think this is almost certainly a cancer, one might consider a total thyroidectomy as a first procedure. And then lastly, just to make the point, as has been pointed out, that thyroid surgery has significant morbidity in children, higher than in adults. This is a large study that published by Julianne Sosa's group a number of years ago, just showing that the risk of endocrine complications from thyroid surgery is much higher in children than in adults. And as in adults, we have good data in pediatrics that the experience of the surgeon is important. The more thyroid surgeries a surgeon has done, the lower the risk of complications. And so I think for all of us, it behooves us, if we're sending our patients to thyroid surgery, to find the most experienced thyroid surgeon who's willing to operate on a patient of that age. In an older adolescent, that may well be an adult thyroid surgeon who's a higher volume surgeon, or basically whatever team we can assemble that has the most experience. Obviously, total thyroidectomies are much higher risk of complications than a simple lobectomy, since you're not putting the other side, parathyroids or recurrent laryngeal nerve, at risk. But still, I think that's important. So I'm going to wrap up right now. I know I've run a little long, but this is kind of a summary. I would think in a stepwise approach about this evaluation, identifying at-risk groups, weeding out autonomous nodules, which are generally not malignant, using ultrasound then to guide the decision for FNA, and then cytology from FNA to guide further management, and focusing as best we can on consolidating care among experienced surgeons to optimize outcomes. So I apologize for how quick that presentation was, but I'm more than happy to answer questions and discuss going forward.
Thank you, Dr. Ari, for your excellent overview on the management of thyroid nodules. We have a few questions. Sriram has asked, dear Dr. Ari, kindly comment, should we do technetium scan or iodine 131 and why for thyroid nodule evaluation with suppressed TSH?
Yeah, so that's a good question. In general, so part of this, I think part of this is a regional difference. So in general, when we can get it, we tend to use iodine 123 for scans if possible, just because it has less cytotoxic effect. But I realize in many places that's not available, and so then you have to make this decision between I-131 and technetium. I personally don't have a strong feeling about that. I think that it's worth using. I think you want to make the right diagnosis. I think that either is probably okay. I might tend a little bit more toward technetium if you have the choice, but I think that I think you have to sort of use what's available. Probably a more important thing to know is this a nodule that might be cancer or not? And a positive scan, a scan demonstrating autonomy will pretty much almost entirely take malignancy off the table. And so I think that's an important thing to know.
Yeah, thank you. Dr. Rajni would like to know, would you use any size threshold for suspicious nodules?
Yeah, so that's, I did not sort of speak specifically about size thresholds. What I will say is pretty much, I'll go back to this slide about this here. I would say in my experience, any nodule that is, first of all, I do not biopsy nodules that are under a centimeter unless they have very clear suspicious features, calcifications, abnormal lymph nodes, mostly because we don't have any, even if it's a small thyroid cancer, we don't have good evidence that weighting is going to adversely affect outcome. If a nodule is over a centimeter and is solid or predominantly solid, I generally will biopsy it. If it is partly cystic or does not have any of these sort of significant features, but particularly if it has cystic components, I often will wait and observe it. I may let it get to be 1.5 centimeters or so. But once pediatric nodules get above 1.5 centimeters, I tend to biopsy them. I admit that I don't have like absolute hard evidence for that, but I think it's important to point out that these thresholds in TI-RADS were designed to avoid unnecessary biopsies in adults, right? In whom there is pretty good evidence that small thyroid cancers may be very indolent and cause no issues, and the time horizon is shorter, right? Children have several decades more follow-up than adults. So this is designed to avoid biopsying adults unnecessarily, and it's not clear to me that that approach is the correct approach for children in whom we don't have such good data about benign behavior of these lesions, and we know that there are pediatric lesions that are cancer that fall into the TR1, TR2, TR3 category. Again, whether you use these exact scoring system or whether you use pictorial doesn't matter. So I'm a little bit more conservative. As I said, solid nodules over 1 centimeter definitely get biopsied in my clinic. And then if they're getting over 1.5 centimeters, I tend to biopsy them unless they look very benign, very cystic. Anything over 4 centimeters, unless it's entirely cystic, I tend to biopsy simply because of the data that I showed you that large nodules may have cancer, particularly even if they're in these categories. Large ones can hide a cancer. Sorry, that was a long-winded answer to that question.
Thank you, Dr. Hari. You have answered the next question of Rajni. Divya would like to know what are the criteria to decide on hemithyroidectomy or total thyroidectomy for a nodule of 4 centimeters and above in a case of suspected thyroid malignancy.
So I would say this is kind of the framework that I use, right? So if I know that cancer is present, right, I've diagnosed it based on malignant cytology or lymph node metastases that are either biopsy proven or highly suspicious by ultrasound. If I know there is cancer there, that's a total thyroidectomy because that is the therapy for thyroid cancer. If I really don't know whether it's cancer or not, then I would opt for lobectomy, which is a much lower risk procedure, right? I think where it becomes difficult is you have to decide how high is my suspicion for cancer, right? So in this category of cytology, where the risk is 70 to 80% or more, is that sufficient, a sufficient risk that I should say, I probably ought to do the total thyroidectomy up front because almost certainly if I don't, I'm going to have to go back a second time to surgery, which is just more procedures, more morbidity. But if I had a family that said to me, listen, I really don't want to take out I don't want to run that risk of thyroidectomy, total thyroidectomy, unless I really know that it's cancer, and I'm willing to assume the possibility, the likelihood, in fact, that I need a second procedure, I don't think that that's unreasonable as long as there's a clear discussion and everyone understands what the risks and benefits are. So I think it all comes down to your assessment of what is the likely risk of cancer. If it's cancer, total thyroidectomy is the treatment as it stands now. But lobectomy I use for diagnosis, or if a nodule is coming out for other reasons. So if it's causing compressive symptoms or cosmetic symptoms that people would like to get rid of, if it's a benign nodule that's large and I'm worried about a false negative result, those are clearly lobectomy situations.
Okay, the next question is by Dr. Ahila. Would you advise diagnostic lobectomy for a report of follicular neoplasm on FNAC Or are there any specific feature on FNAC in children that would differentiate between follicular adenoma and follicular carcinoma?
Yeah, no, that's an important question. So the short answer is no. There is nothing on cytology that will distinguish within this category of the suspicious follicular neoplasm. There is nothing that will distinguish between benign follicular adenoma and follicular carcinoma, or follicular variant of papillary carcinoma. In fact, we just published a paper in the European Journal of Endocrinology a couple of months ago looking to see whether there's anything sonographically that might help distinguish. If you get this result back, can you look back at the ultrasound and try to tease it out? And there's nothing, basically. So the rates of malignancy in different studies are quite different in this category, and I think that relates to variability in cytopathological interpretation. Nevertheless, the rates are somewhere in the 30 to 70% range for malignancy in this category, and there's not really any good way of distinguishing based on cytology or ultrasound. And so when we get a result in this category, we resect it. And that's partly driven by we have institution-specific data that our rate of malignancy is about 70%. And so I resect these and I use lobectomy. One could argue about whether oncogene testing might be helpful, right? If you found, for example, a RET fusion or some known oncogenic driver, similarly to these other indeterminates, you might be able to then go to total thyroidectomy for diagnosed cancer. But short of molecular testing, this cytologic result gets a lobectomy.
Thank you. Dr. Ashu wants to know, in a child with autoimmune hypothyroidism, if the child has a thyroid nodule over 1 centimeter, do you do FNAC on these lesions?
Yeah, so that's an excellent question. And this issue about the association with autoimmune thyroid disease is I would say a quite actively discussed and debated issue right now. And whether autoimmune thyroid disease increases the risk of nodules, increases the risk of cancer, increases the risk of malignancy in a nodule that you may find. I think those issues remain unsettled in my mind. And so I basically manage nodules in children with autoimmune thyroiditis in the same way that I manage them in everyone. That is, I evaluate them by TSH, presumably they're TSH, they're not going to have autonomous nodules. I evaluate them sonographically. If they meet sonographic criteria for FNA, I biopsy them, and I interpret the cytology accordingly. I don't really modify the approach because of the presence of autoimmune thyroiditis, simply because I don't think that there's good evidence for doing that in children. Other than I will say that there is some evidence that autoimmune thyroiditis can cause some changes of some Hürtel cell changes. So sometimes you'll get atypical results, AUS results that say, lots of Hürtel cells, and that raises concern about a Hürtel cell neoplasm, like a Hürtel cell carcinoma. And one has to be a little careful because autoimmune thyroiditis can definitely cause Hürtel cell changes. And so if I get that specific result, atypia with Hürtel cell changes, and I know the patient has autoimmune thyroiditis, I might not immediately jump to, thinking that that's likely to be a malignancy. I probably am going to repeat that aspiration after a period of time, and I might be more inclined to watch that nodule, thinking that it might be just the autoimmune thyroiditis that's doing that.
Thank you, Dr. Ari. One more question. Following a report of malignancy after diagnostic lobectomy, how soon or how late can the surgeon go back for converting it to total thyroidectomy after the initial surgery?
Yeah. So I'm always hesitant to speak for surgeons. Every surgeon is their own species, and so I would say that I tend to defer those decisions to the surgeon based on their sort of impression of, the difficulty of the initial procedure and the patient and sort of how they're doing. I don't think that there's necessarily, from an endocrine perspective, I don't think that there's a particular need to wait or not wait. The only thing I would say is that, before anybody goes back in to do a second surgery, I would want to be very sure that there's no additional surgery that needs to be done. That is, that it's just the other lobe that's coming out, that there doesn't need to be a lateral neck dissection, or a central neck dissection. And so if a thorough survey of the cervical lymph nodes was not done prior to the first surgery, I would certainly be doing that prior to the second surgery to make sure that I'm not having to go back a third time to find abnormal lymph nodes. And sometimes that happens. Sometimes, a nodule comes out without a suspicion for malignancy just because it was large, and then they find a cancer, and then they send them to a center, and we say, well, we really should have looked for, lymph nodes the first time. So that's why I encourage people, whenever there's a nodule, always to just look at the cervical lymph nodes and make sure there's nothing abnormal there.
Thank you, Dr. Ari. You have one more. How do you follow up a patient with euthyroid multinodular goiter who is antibody negative with a strong family history of thyroid cancer?
Yeah, that's a very interesting question and not a simple answer. Again, I think, so, familial non-medullary thyroid cancer, meaning, strong family history of cancer that is not medullary, it certainly exists. There are families that have these histories. It's not very common, but it does exist. And it's not so well defined what exactly constitutes that syndrome. How many family members constitutes a family history, and what degree relation. So I think that it's reasonable to be careful. And I think that certainly if a patient has multiple nodules and there's a family history of thyroid cancer, I would watch that patient fairly closely. I would say I do not do surveillance of nodules more often than once a year. So unless, again, there's something very specific that I'm watching. As I showed, benign nodules really tend not to grow very much in less than a year, and sometimes they don't grow at all. And so I think shorter intervals than that probably are not necessary or useful. But I think if there's a concern based on the exam and the family history, I think monitoring is reasonable, and there's not really good data to say how often that should be. So I kind of start with a year and then space out if it seems appropriate. I would also say that increasingly it's becoming clear that at least in iodine sufficient populations, children who present with multinodular goiter, particularly at a very young age, one should think carefully about the possibility of a genetic syndrome such as P10 syndrome, Cowden, or Dicer-1. And identifying those is important because they are associated with other tumors, some of which can be worse than thyroid cancer. And so surveillance for those other tumors would be important if that diagnosis were made. So I've recently diagnosed several children with Dicer-1 mutations because they showed up aged 13, 14 with multiple nodules. And anytime that happens, I refer them for genetic counseling, and it's not uncommon to find one of these underlying syndromes that then informs their further care.
Okay. In the case discussed by Dr. Dania previously, would you advise surgery for the autonomous nodule based on size more than 4 centimeters?
Yeah. So I would say all of these comments about size criteria and so forth, right? That is all relevant to the nodules that are not autonomous. So when I talk about false negative rates, being higher in large nodules, that's already once you've excluded autonomous nodules. So autonomous nodules, as I think I mentioned, in our experience, and I think if defined in a rigorous way, behave similar to adults and are very unlikely to be malignant. And so for that reason, I don't necessarily recommend surgery based on size. I think surgery is based on the clinical scenario. And so I would say with a nodule that big, the considerations are, long term, right? This nodule is not going to go away. It might get a little smaller with methimazole or carbimazole, or it might not. But it's not going to go away, and the hyperthyroidism is not going to go away either. And so I think that's the decision. I think that personally, and by the way, that case was a remarkably active hot nodule. Most autonomous nodules in children are not that active with free T4s above the reference range. They tend to have mildly elevated T4s, and they're not usually so symptomatic. So personally, if I had a good surgeon who could do this lobectomy safely, I would probably take it out because it's not going to go away. It's going to be large, and it's probably not going to get smaller. And we're going to be treating the hyperthyroidism for a long time. I don't think radioiodine ablation is a bad idea. I think one could consider it. Personally, at 10 years old, I might wait a little while if that was the way I wanted to go, because I think the data are not in. We don't really know long-term about secondary malignancies, and so I think I might sort of treat her with carbimazole if that was working well, and think about ablating her in a couple of years, just on a the theoretical possibility of reducing that risk of subsequent malignancy, which is again unproven. So I think it depends a lot, honestly, on what resources are available to you. If you have a good surgeon who you trust, who can take out that lobe, I think that's reasonable. It's a relatively low-risk procedure. You're not putting the other parathyroids or nerve at risk. So I think you have to weigh the situation a little bit.
How long would you, sorry, I can't see some of them. How long do you follow a benign nodule?
Yeah, nobody knows the answer to that. We've talked about this in the guideline committee. So nobody knows how long to follow up benign nodules in children. I think the only longitudinal data that really exist in children are these that I mentioned. And, this doesn't really tell you the answer to how long you have to follow. We did have, of this false negative, right? The real question is, do benign nodules ever turn into cancer later on? And nobody knows the answer to that question. Among this false negative rate that we had of 2.5%, that was 6 nodules out of about 215 or so. Some of them turned out to be cancer several years later, 5, 6, 7 years later. They were all indolent cancers and easily treated. But I don't know that we have a definitive time frame that we can say, if you followed it for X number of years, then you can be confident that it will never ever turn out to be malignant, and you can stop following it. I do tend to space out surveillance. So if I have a cytologically benign nodule, I follow it for a year, it doesn't grow, I'll often follow it in 1 more year. If it still doesn't grow, I often will space out and say, you know what, why don't we check again in 2 years, right? And then depending on how that looks, I might check again in 2 more years or 3 years. And then I basically, then they become adults and I send them to the adult side and I make them decide. But that's not really evidence-based, right? I think we don't really know. And so I have erred on the side of continuing to follow, but at decreasing intervals as they show no change. I realize that's not a very rigorous answer to your question, but unfortunately, that's what we have.